So then the best chance is in the prevention corridor after excisions. And this is just adjunctive therapy. And I realized that this shall continue for 2 months for the first timing for us to evaluate it, and also for going on if necessary. As you know, as the patient comply and you see the potential chances for you to go on, then you may go on after you see the maturations of the scar. With that, I would like to stop sharing my cases and thank you very much for your kind attention. Hopefully that the discussion would be fruitful, although I understand the timing has been quite limited, but I would send the microphone back to moderator, Dr. Pai.
Thank you, Teddy. So we have a comprehensive overview of everything that can be done by a dermatologist, a cosmetic surgeon, and a plastic surgeon. I think now we need to go to the questions because there are a few questions in the chat box. We have a question which asks, medical scar treatment protocol of scar after scar revision surgery. I think this has already been answered by you. Am I right, Dr. Teddy?
Yes, I think I have presented clearly on how people would take the message with that questions.
Correct. Dr. Gold, the next question I'd like to ask you, we have a question saying, silicone sheet versus gel, how do you compare the pressure release and effectiveness?
So I think over time we started with, all we had was silicone gel. And I think there's enough studies that have been done that compare gel and sheeting, and they both work. And I think it's much easier, if you look at 100 of my patients, probably 90 of them, 95 of them end up with silicone gel right now. I still use sheets on certain people if they have areas that are difficult to apply a gel, or they have nobody at home to help them very easily. I'll use a sheet, but I use gel 90% of the time now. I think that what we have with our new formulations, they're cosmetically acceptable. Patients are not opposed to using them. And as I said, if they're not tacky and they don't feel bad on the skin, people will use them. So I like gel.
So the next question I have for you, Dr. Gold, would be the role of 5-FU in keloids. Would you like to apply it topically, or would you like to use it as an injectable, or you just want to leave it alone?
So I think if you use 5-FU, again, I don't use a lot of 5-FU because of the cost. It's just an added cost to me. So, but I think if you use it following fractional lasers, you can use it topically, but I'm a much bigger fan of injectable 5-FU. How about you guys?
We have been using topical here on the wound. Injectable, I don't have experience. Dr. Teddy, do you have experience of injectable 5-FU?
Thank you. So I did not use it myself, but I know one of the giants in China using this 5-FU is Weilu in Shanghai. I think he's quite successful with long years experience, but very patient to take care of keloid, which comes with disaster in many areas of the bodies. Every time I see his presentations about the use of 5-FU is amazing. So just as the baseline for you who are interested in using 5-FU, I believe you could apply it in 50 milligrams per milliliters, and half milliliter for centimeter square would be the dose for you to perform, just to avoid the potential complications. But then there are also potential for you to combine the 5-FU with corticosteroid with 40 milligram per milliliters. I usually use the 10 milligram per milliliters, but then it's quite good to know that you could, make a mixture, 1 corticosteroid and 9 5-FU. So then the effectivity of 5-FU is said to be greater rather than the small dose of the corticosteroid. But yes, that friend of China really have a great experience using the 5-FU, which is quite promising.
Right, thank you. Because Dr. Gold, I think in our DASL meets and our 5cc, we had speakers, showing their work with 5-FU.
I mean, there are people that work with it a lot. I just don't have a lot of experience with it. As you know, to me, I've just found the benefits of intralesional corticosteroids to be my favorite. And so that, you know, I probably have never changed how I approach the patient. There is always a cost involved, and you know, even if I'm getting insurance reimbursement, if I have to bill for steroids and 5-FU and this, the insurance companies, at least here, are not happy. So we try to keep it simple. But I do think that, you know, if you have 5-FU and you're used to using it, there's enough evidence out there that it works.
We had questions like, what is the best treatment for hypertrophic scar, and the medical treatment protocol of scar after scar revision surgery. But I think we now have an answer to that question, what's the best treatment? There is no best treatment as such. You have a surgical option, you have a laser option, you have a silicone gel option, and in some of these things, you know, beyond just masterly inactivity. So the role of diet in keloid has been asked by someone. As far as I know, you probably have to get the patient's weight down. What I have seen is patients who are obese with the keloid, they put pressure on them, especially on the chest. So maybe the diet you need is to get the weight down, maybe a nutritionist.
Allow me?
Yeah.
Yeah. If you could detect that the potential role among many factors that potentially has the influence on the development of the keloid, like the one that I presented as an example with the sebum reaction, so then, you know, low diet would be controlling, at least supporting with the recurrence of the keloid after you treated the keloid, after you treat the keloid.
All right. So we have another question from Mysore Srinivas Venkatesh, which says, he says that the results are very good when he uses surgical excision combined with the high dose brachytherapy, which he thinks is an effective combination. So I think, Dr. Gold, you used a lot of plastic, you used a lot of radiotherapy in keloids, and is there a problem with the healing part of it after you finish the therapy? I mean, does it take time to heal?
So brachytherapy plays a nice role, as does radiation therapy. I like the role of, I think brachytherapy has the potential to go deeper in the skin and cause more problems. That's why I use superficial radiation, but they both work. I do think you have to be aware that if the radiation goes too deep, you're definitely going to interfere with wound healing, and that's a problem. But again, the way our protocols in the U.S. are set up, we are giving 3 days of radiation immediately following the surgical procedure. So surgery, the next day they start their radiation, they get 3 doses of radiation, and they're finished. And it actually does not interfere with wound healing at all, the way we do it. And we just finished a study looking at 1 year's worth of recurrence rates in 96 patients that were treated, and we had a recurrence rate of less than 10%. So again, that's really impressive to me.
Yes. We also have a maxillofacial surgeon here who's asking, he needs to know more about accidental scar management and techniques for facial scar revision. I think in a nutshell, Dr. Teddy, could you help him out? Accident scar management and techniques for facial scar revision, apart from the use of silicone. And the next is, can a combination of intralesional steroid along with 5-FU be given to treat keloidal scar, and what's its efficiency? So how long, effectively, I'd like to ask how long after 5FU an intralesional steroid, would you give the intralesional steroid or vice versa? Somebody needs to know, Michael, Dr. Seema Rani, whether you can use intralesional steroid along with 5FU, or would you use it separately?
So I'm going to respond first.
Yes.
Okay. So the questions was too general, so then I would not be able to respond in terms of the techniques. But just with the general principle of plastic surgery technique, with the maxillofacial surgeon, it's just the same. With the dermatologic surgeon, it's just the same principles. So that the delicate surgery, respecting tissue, and also very good alignment without tension are the keys for you to tackle. Then this is a good point when you deal with those whatever problems, and mostly it's about the accidental scar, and also with the surgical scars would be similar, because with the accidental scar, if the edge of the scar is not in a smooth line, so you need to make a smoother line or edge so that you would end up with a nicer scar. So then with those principles, and also try your best to do it with best technique, then you may follow it up with silicone gel after the suture removal. The stitch removal is the timing for you to start. But of course, you can combine it with whatever modality. If you see that the control of the silicone is not really as you expect, you may start your corticosteroid injections. And in my practice, you do not need to invite the patient to come back every week, just 3 weeks. Following the second healing phase, it's just enough. Do not necessarily to be quite shorter. Then for how long, it depends on your cooperation with the patients. Until you could get the maturation comes into obvious fact. Then combination with other treatment would be also just welcome. In my own practice, I do not have personal experience with using the 5FU. Thank you.
The last question in this is, what is the ideal time to start the intralesional steroid post-excision? Both of you, this would be a question which you could answer very briefly, is once you have excised your keloid or you're done your fractional CO2 and remove the keloid, which is the ideal time to start the intralesional steroid? Would you like to wait 1 week, 2 weeks? Because what I heard and what I gather is that I wait about a week to 10 days for the regeneration to start, because there's no point in injecting dead tissue with steroids. It's better to wait for a week or 10 days, wait for the regeneration to start. So when the fibroblasts get active, that's perhaps the best time to give the intralesional steroid. Do you agree? Would you like to change something or add something?
So again, I probably go against conventional theories right now. If I'm excising a keloid and so forth, I actually excise the keloid and I put intralesional steroids around the excision the day of the surgery. Hypertrophic scars and keloids are different. So even if we're excising and taking a border, I'm still trying to make sure that I treat the area around the excision. I don't inject the excision itself. So maybe it's because my patients will come back 2 weeks later for sutures, usually, depending on a week in the face, 2 weeks somewhere else. I want to get started early. Most of my patients, if it's a keloid somewhere on the body, they're not going to come back in a week. And so I sort of have just adapted to, I inject around the borders the day of surgery. And I've done that for years now, which is probably against the plastic surgical world.
Teddy, would you like to add something to that?
Yeah, thank you. I would like to be quite sharp in responding to the questions. In my practice, I would not come into injections at the very beginning after my surgery, because injection is painful. I would, allow the patients to experience the surgery as a memory of nice surgery. I would only take my chance to start concerning or considering injections when I see the elevations of the newly formed scar that was or that is not well controlled with my silicone. So then that is the point for me to start with. Then it needs discussion so that the patient would comply. Otherwise, if she would agree only at the first chance to start with the injection, but she or he would not come back, then there's no point for me to start. So agreement between myself and my patient would be very, very important. So when the patient get agreed to come back, are you going to come regularly? If you see that, it started to elevate, then that's the point for me to start
Right.
with.
Right. But I do injections, again, the day of surgery because they are numb. And the patients don't feel it. So your point is correct. If they don't come back, it's worthless, and they don't agree to come back on a regular basis, you're wasting your time and effort. But when I do it the first time and they don't feel it, they always will come back, and get it the next one. Then we have to go and work with them to come back. So
one of the things that I have noticed in practice is that some of these chest keloids have an overhang, and underneath the overhang, you get a lot of collection of sebum and material, which can cause constant infection. So I want to make sure that that's cleaned by the patient regularly, and I remove the hairs of the chest for about 3 centimeters beyond it, because these hairs are very thick in some of these patients, and they tend to prick the keloid and have a constant stimulation to make them grow. So a margin of hair removal around the keloid is perhaps one way of minimizing the irritation to the keloid, which makes it grow faster.
I agree.
Thank you, Dr. Gold. Thank you, Dr. Teddy. I think we have finished all the questions. I thank Mandarini for having organized this wonderful seminar and lectures from different parts of the world. And I'm sure if there are more questions in the future, they will be directed via Mandarini to you and to Dr. Teddy. Thank you. God bless you all. And good morning, good afternoon, good evening, and good night to those people, depending on which part of the world you're in. Thank you very much. Bye-bye.